Sounds
Thanks so
good.
much. Let me
Yes,
just get this
hello.
out of here. Hello. I'm so glad you can
Hi.
join me. I'm so excited to chat with you.
Yes, me
Literally like
too.
across the world.
Where are
I'm
you
over
right
in
now?
Mass. I'm in Massachusetts.
Okay, yeah, a 4-hour difference?
Yes. Yes.
Yeah,
So
it's 3:36 right now for me.
yes, it's 7:36 for me at night.
Oh my goodness, that's so crazy.
I know, right? So and I see that it's like bright. It looks like you have natural lighting there.
Oh, yes, and we have the summer solstice coming up. So right now, the sun is setting pretty late here in Fairbanks, Alaska. It looks like it's gonna set at 8:20 PM. Tonight, and
Oh, wow.
we'll continue to gain daylight until June 20th or June 21st, which is the longest day of the year, and we'll get up to like 24 hours of daylight here in Alaska.
Whoa, that's so cool.
It's crazy.
So if it's gonna set tonight at 8:20, what time do you have sunrise?
Let's see. The weather app is saying 7:32 a.m.
Oh,
tomorrow
wow.
morning.
Okay,
Hmm.
that's really cool.
Yeah.
That's cool. So tell me your story. Like Alaska. Were you born
Yeah.
there? Where did you move there? How did we get to Alaska?
So my husband's in the military,
Yeah, I gotcha.
and I was born and raised in Dallas, Texas. So
Okay.
I've never lived anywhere else ever in my life until I married my husband and we got stationed in Alaska, and we've been here for 3 years now.
Oh, wow, okay. So you're
Hmm.
from Dallas. Gotcha, gotcha.
Yes,
And,
yes, very different.
I bet. I mean, Dallas is probably a lot different from Mass, never mind going there from to Alaska now. So tell me about, how were you a nurse already in Dallas, or how did that
Mm-mm.
No.
No, so I met my husband when we were freshmen in college, when I was doing like my prereqs for nursing,
Mhm.
and I did my nursing in Fort Worth. So I got my associates first from TCC, which is in Fort Worth, Tarrant County College. And then I got my bachelor's online, my bachelor's of science in nursing through Texas Tech University. So once I graduated with my associates in nursing, I was about 22, and my husband was also finishing his fourth year of um, college, and we got married shortly after we graduated. And then he got his military orders to go to Alaska. So, I mean, it was so much happening that year that we got married. He has to go to training. Then we're going to move shortly after to Alaska. So I knew that it wasn't even worth trying to get a job in Texas because I just tried to focus on studying for my NCLEX and getting my Texas nursing license, because Texas is a compact state and
Mhm.
Alaska isn't. And getting your nursing license in Alaska can be a longer process. So I just knew that, I mean, once we were going to be done in Alaska, we were eventually going to move back to the lower 48, and I wanted to keep that license active. So I'm like, I might as well just take my NCLEX here in Texas. And yeah, so we moved to Fairbanks, Alaska, and it's so funny because all of my nursing friends back in Dallas, it's a big metroplex. So you have like 30 plus hospitals you can choose from to apply for a new grad residency program. And when I found out we were moving to Fairbanks, I'm like, wonderful. I'm Googling hospitals in Fairbanks, Alaska. One. And I'm like, are you kidding me? And I knew I wanted to do labor and delivery.
Okay.
So that was very intimidating because labor and delivery is a very competitive specialty. Um, and I told myself, "There's no way I'm going to get this job. Like, I don't have a plan B. If I don't get this job here, then I'm screwed for 3 years." So that was a little intimidating, but
Yeah.
I applied to their new grad program. I went ahead and did an interview for labor and delivery, peds, and NICU, and I got offers for peds and L&D, so I went ahead and took the L&D, which was very exciting. I'm like, "Okay, I think we're gonna be good for the
Yes.
next 3 years."
Yeah.
And yeah, so I haven't done nursing anywhere else besides Alaska.
Wow. Wow.
Yeah.
What's it like that there's only one hospital in the area? I mean, must be
Oh my
pretty busy,
gosh.
I would think.
Um,
Although the
I
population
mean,
was probably not as high. I mean,
well, for labor and delivery, we have a lot of travel nurses that come because, I mean, it's like a very, like, transient, city. There's lots of military families that come here, so, like myself, then we'll be here for 2, 3, 4 plus years, then we leave, so it's kind of, like, hard to keep staff. There's only, like,
mm,
a small population of people who are, like, born and raised Alaskans, live here, are nurses, will stay here for a while. Um, but let's see. Mm, what was the question again? I'm sorry.
that's okay. I was asking, is it really busy because you're
Oh,
only one hospital in the area, or is it impacted because your population might not be as high as other hospital areas, like over in Texas?
yeah. Yeah, I think it's not as busy as the hospitals down in Texas, which is weird because we serve a large population, which is like all of the interior of Alaska. But when we get travel nurses that come and do their contracts for 12 plus weeks, they'll come from big city hospitals that will have 500 births in a month, and we're averaging about 100.
Oh, wow.
Mhm.
Wow, that's so interesting.
I know. So it's so weird to say that, yeah, it's only one hospital and we're serving all of the interior, but I mean, we're probably not as busy as like these big city hospitals.
Right. And would you say that so I'm just imagining the population in the area, as far as like the moms who are birthing babies, and I guess would you say a lot of the moms are actual the military moms, parents who are the women who are having the babies?
So we have a military hospital. So I live
Oh,
on a military base. So
okay.
the military base is Fort Wainwright, and they have their army hospital, which is Bassett Community Army Hospital. So if they're military, then they will go ahead and give birth in the military hospital.
Oh,
Sometimes, depending on the insurance, like if they want to upgrade their insurance and give birth outside of the military hospital, which is, it's common for people to do that, then they will be able to find a clinic in town and they will be able to deliver in our hospital. Um, Sometimes, let's say that Fairbanks is the only hospital that's close to them at that time, it's not like we're going to turn anyone down, because of their insurance, so,
right.
um, we still get a mix of things. It's not just Army people giving birth. We have a lot of our Alaskan Native moms that are flown in from remote cities or their villages to come give birth because they only have like clinics or like small centers in their villages and in their remote towns. So then they'll have to get flown in here to be able to give birth.
Okay, gotcha, gotcha. So I hear you say villages, which I'm sure a lot of people don't hear so often. Um, in, in the continental US. Tell me, what have you learned about, cultural differences in Alaska when caring for your patients
I think
and families?
when I think of Native moms, they're known for their labors to go really fast. Never trust a Native mom. I
Really?
they usually yes, they usually go natural, and they're very stoic in like a positive way when we're triaging somebody and we're like, okay, what brings you in? And they tell us, oh, contractions, or oh, my water broke. And we're checking their cervix and it might be like 6 or 7 centimeters. And they're just like looking at you. Yeah, I'm here for contractions. They hurt a little bit. Yeah, sure. So it's like, oh my gosh. So it's just like you kind of have to put a little pep in your step when it comes to that. And they will get flown in around a month before their due date, so they'll be staying in a hotel. Sometimes they get really homesick just because they're waiting for something to happen. So if there's no indication to induce them, like they don't have any risk factors, then we can't really do much until their water breaks or they're making cervical change or they're having, contractions that are pretty close together, or if they go to the clinic and maybe they have a non-reassuring strip and or an NST, and they'll get sent to the hospital to for further evaluation. And if we have to keep them, then we'll go ahead and keep them. Once they're done giving birth, they're ready to go. They want to go back to their village as soon as possible. It's just kind of like, can we
Right.
leave?
Okay, so what I'm hearing is there's lots of distance to consider, right? So what you're saying
Mhm.
is all of the appointments that we're used to with our prenatal care, they have to actually move there in order to have that care in preparation for the day of active labor.
Mhm.
Ah,
Yes. And I mean they don't have vehicles here. So I've seen in most cases when I triage patients that don't live here, they'll get taxi vouchers that will send them back to the hotel or come back to the hospital. Sometimes they have friends or family members that live here in town. So then sometimes they stay with them as well.
oh wow, that's really interesting. So is it different as far as like does do Alaskan natives have any additional coverage in a sense where they for that those stays, or is that something that's all out of pocket?
I want to say they do. I think
Okay.
they have a different type of insurance. It's not coming out of pocket, I wanna say. They might even have a little bit more coverage than other insurances
Okay.
because they're native. We
Yeah.
also have a native clinic, and I wanna say that it doesn't matter, like, the percentage. I think you have to be maybe at least 1% native. I'm not too sure. I have to, like, look it up, but you're able to get care from that native clinic and just get the benefits
Oh, okay,
as
that's
well.
great. That's great. And I heard you
Mhm.
say if they have to get induced. Now, of course, I never worked labor and delivery myself, but research has shown frequently, high induction rates. Do you see that as well in Alaska or less often?
Um, unless it's, like, medically indicated, I wanna say that they have to. I know it's, like, a big stigma where
Mm-hmm.
it's, especially with social media nowadays, people feel like they can't trust their providers or their nurses or hospitals, and they might just do a Google and think, oh, pitocine's bad, or I don't want pitocin, and they're not like really educated on the induction process and like how we start and our logic behind it. So sometimes they'll just come in here and be like, give us a birth plan, and it's just everything that we were planning on doing, like, it's just kinda contraindicating, like, "Oh, I don't want this, I don't want that." So, sometimes it can be a little difficult with that social media aspect, um, but I do wanna say that Alaska does have the lowest C-section rate in the US. We're
Okay.
averaging, 24% when the national average for the lower 48 is anywhere between, I wanna say, like, 33 or 34%, and that really has to do with how many midwives attend these deliveries and how hands-on our midwives are and how patient we are with our inductions. I
Hmm.
see a lot of the time we'll have travel nurses come and they'll get their like 2-day orientation and then they're on their own. But we're pretty helpful and we're a pretty like close knit unit. I know we get the rep that, oh, labor nurses are mean girls or that's where all the mean girls go, but our unit's pretty helpful, and a lot of our travel nurses will tell us, "Whoa, you guys are so patient with your with these moms. We would have already cut this mom if back in Texas or back in Mississippi," or, "Oh, yeah, our
Hmm.
OBs would find a reason to say, 'Yep, you haven't made any cervical change in 12 hours, you have to go for a C-section.'"
Hmm.
And here it's very different. We try to follow like our patients' birth plans and just honor their wishes. At the same time, just educating them on the risks and the benefits, and usually, they're very trusting of us and all of our midwives, and we also have our amazing OBs that are there taking care of our higher risk patients and performing the C-sections, and if the midwives need backup, like, let's say, there's, like, not very like, it's a Category 2 strip and we are looking maybe into a potential C-section. Our midwives are really good at communicating with our OBs, kind of keeping them in the loop, like, "Hey, I might need you," or "Hey, can you come in to the hospital and evaluate this patient and tell me what you think?"
Gotcha. So I want to give you a little bit of my experiences so that you can tell me how it might have differed for me if I lived in Alaska and had you as my nurse and your team. Okay. So
Okay,
um I would say I'm Portuguese. And
okay.
over in New England, we are known to be sort of loud, kind of sassy, and a lot of us, let's just say, aren't embarrassed when we're in pain. Let's just say that, okay? So you can picture, like, when I was in labor, it, I have 3 children, so when they were all very different experiences, but I would hear mom screaming across the hall, and I'm like, "Oh god, it's almost my turn, like, I'm gonna be her any minute," like, it's a wild time.
Yeah.
There's probably lots of swearing going around, and I remember screaming at my mom. So for instance, my first labor with my first child was the worst of my
Mhm.
3, and, um basically all my prenatal care was seeing this one. She was a midwife, actually, but
Nice.
then the day of labor came. My water broke. I went in and it was not her, right? It was a physician on call. So the physician on call, who fortunately I also knew, she was in the same office. She came in, she saw me, she saw my face, and she was like, she needs an epidural. I got the epidural, and things really went downhill from there because it's like that. The often hear like that one side didn't work, and then my pressure plummeted. I had to get
Mm.
bolused and had like a rapid response, and then
Oh
after
my
the baby,
gosh.
the baby was febrile. I couldn't do skin to skin. I also was like bleed. My placenta wouldn't come out. It was like over
Oh my
30 minutes.
gosh.
Then another physician came in, and I remember like baseball clots coming out, and I was just like
Oh my
delusional. and they gave me, like, an antidote to in the arm, don't ask me what it was, to stop the bleeding, and it was just horrible. I remember I couldn't even
Oh
hold
my
my son
gosh.
because I was so out of it. Um, so it was a really bad time, but and it was very, like, chaotic to me, especially your first baby, because you don't know what to expect. It's so scary, whereas my second baby, I went natural because of that first experience. I was like, "I will not do
Oh,
that. I will figure it out." And my best friend was my L&D nurse, my very
oh,
best friend. So
yeah.
she gave me, like, the gas. I don't
Okay, the
know.
nitrous
Yeah,
oxide.
I don't know
Yeah.
if they use that often there, but I used
Mhm.
it at the very end and it helped me and I got through it and he was just, like, coming out of me. Whereas my
Oh, good.
third, I was like a very, I knew what to expect. I was ready. It was just me and my husband. It was peaceful. The sun was setting. I had meditation music. My water was breaking while I was on the ball, but I was induced. Although they elected to induce me. They offered. And I said, "Okay."
Okay.
And that actually happened my second, so they offered. So, again, the first 2 were much more, like, chaotic, and then the third one was very I was so mentally prepared. I knew my body was gonna do it. The baby, after she came out, it was just like, "Okay, we're all set," and so, tell me what things might have been like or how they could have been different if I was over in Alaska.
Um, were you a nurse when you had your babies?
Yes.
Oh my
I'm sorry,
gosh.
I was a brand new NP when I had my first baby.
Okay, I'm just trying to figure out if you had the nurse curse with your first baby.
I
Oh
hear that
my
all the time.
gosh.
Tell me more about this nurse curse.
Oh my gosh. Before I was a labor and delivery nurse, I just fantasized having children and how that was going to be. Now, almost 3 years in, I am petrified of giving birth. With everything that I have seen, I'm just traumatized and I am so nervous, and I'm like, "I hope I don't get the nurse curse." Um, what that looks like in labor and delivery is honestly exactly what you just described.
Great.
Have having my blood pressure tank after an epidural, I fear that. Having my baby, like, come down, like, during, a contraction, like, the heart rate's dropping and it's just not coming back up,
Hmm.
I'm terrified of that. Giving birth and either not having my placenta come out or hemorrhaging, that is my biggest fear. Having my baby get stuck, like their shoulder,
Mm,
oh my gosh,
I
having a
can't
fourth
imagine.
degree tear, oh my gosh, I'm scared of all of it. Um, so that is what a nurse curse looks like for me,
So,
either one of those or all the above.
so what you're saying is, if you're a nurse, your first baby is likely to be hell.
I would hope not, but it could happen. I don't know. I'm not a superstitious person, but when it comes to nursing, it's just
It's
that's
a
the
whole other vibe.
exception. Like, yeah, it's a whole different vibe. You don't say the Q word.
Yeah, right.
You don't want all of this stuff to happen to you during birth, but I mean, I don't know, your
You
chances of it happening, I feel like are
right.
a little higher.
So is there a way to prevent this? Can we can we
Oh my.
teach the people? Do we just go in and be like, "Give me the epidural now," and then, have this ready? Like, what can we do?
You know, so for like your blood pressure that tanked during your epidural, um, I don't know if they did this with you, but before we give our patients the epidural, we're calling anesthesia and we're getting orders. And one of those orders is giving our moms a fluid bolus to prevent something like this happening. Sometimes that fluid bolus
Mm.
before the epidural isn't enough, and we might have to give another one after if we're seeing a trend in those blood pressures coming down. Sometimes we'll also have medications in hand. We have a care set that gives us parameters as to like when it's appropriate to administer these medications. So if, like the blood pressure is just hanging down low, then we'll give them a dose of ephedrine, and then after a certain amount of time, depending on what her blood pressure is, then we'll give it again. So I don't know if I'm not sure how if they did anything before, your epidural, but, um, common practice here is giving a bolus beforehand.
Mm,
We'll have anesthesia hang out maybe a little bit, maybe like 10 or 15 minutes after the epidural is done, because 'cause they're out in the nurse station and they're charting, and before they leave the unit, then they'll come back into the room and just check on the patient, make sure that the patient's getting coverage and that the vital signs are stable and that we don't have to give any additional medications for the blood pressure.
gotcha. What do you think's a bit different between the nursing there versus in the US? Do you like patient ratios any different or
Our hospital, I feel like they follow the A1 standards pretty well. Like, we always have our hospital policies up to date, so we don't have to worry about, like, "Are we following A1 standards?" Like, as an independent nurse, like, "Is my license covered?" Like, "Is the hospital policy in line with all of these standards?" And we're put in a great position, and we're put in a position where we're striving for success because I can just print the policy, take a look at it, and trust that it's aligned with our A1 standards. So in the
Mm,
event of some sort of litigation, if I'm following our hospital policy, then I'm covered in a sense like that. And I want to say that not that it's better, but just having Alaska as the only state that I've ever practiced nursing, my insight comes from all of our travel nurses. I'm a sponge. I love to just know what it's like in the real world, or like how is it going to be when I go back to, Texas or any other state where my husband is
yeah.
stationed? Is it going to be the same? And I've heard that we have really good patient ratios. We're in LDRP. So in the event that I have a labor patient and I deliver her and there's no one in triage, we don't have an induction coming in. Uh, Most of the time, then we'll just keep our patient until our next labor patient comes in, and then we'll hand her off to our postpartum nurse, who is our coworker right next to us, who has maybe like two couplets. Then we'll give her our patient, and then we'll take on the other um, laboring patient that is getting admitted. A lot of our travel nurses come back and they love our hospital because we have like really good support, and they like to tease and say, "Wow, you have it so good here." And I'm like, "Don't say that." It's like, "Oh yeah,
Yeah,
I come
it's like
from
scary.
hospitals that have." Yes, it's
Yeah.
like, "Oh yeah, once we're done with our recovery, like at like hour 2, we're rolling this patient to the postpartum unit because we have other patients waiting for us."
Hmm.
Like, it's just go, 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 just super fast paced, just, very divided. She's like, "There LDRP, like, I've never worked in an LDRP before, just labor. This is like, I like this," is what I hear a lot.
Okay, so I noticed that you wrote LDRP, and I'm like, let me look this up because usually I hear like L&D nurse or postpartum nurse, right?
Yeah.
So for you, it's both. That's what you're
Mhm.
talking about. So tell me what a typical day is for you with a labor.
Okay, so for a labor, we'll get report from day shift, and if they are in early induction, meaning maybe we have them on, medication like misoprostol and they're not on Pitocin yet, then
What's that?
an appropriate misoprostol, it's another induction medication that we use, and it's to just help soften the cervix, get it nice and soft and stretchy. Like, that's like the main focus versus, oh, we want her to start contracting. If she's 0 centimeters or like 1 centimeter, like super like high and thick, and like we can't even like reach the cervix, then we really want to focus on just priming the cervix. And after we're done with all of our doses of misoprostol, then we'll reassess and see which other induction method is appropriate for this patient.
Gotcha.
So yes, that's what we use early on, for like our first time moms, or if they don't have in like their cervix isn't open just yet, then we'll go ahead and start with that medication most of the time. So if they are on that medication, then it's totally appropriate to have two patients. If one of your patients goes active, then you would hand off one of your labor patients to another nurse. And that means, oh, she's making cervical change and we're switching her induction medication to Pitocin. Or she is looking more active. She's in 10 out of 10 pain. She's requesting an epidural, then we'll go ahead and hand off our second labor, and then we'll have this patient as a one-to-one. If it's a high risk patient, usually it's a one-to-one as well. So if it's a TOLAC, which is a trial of labor after a C-section, if they've had a history of a C-section with the, prior pregnancy for whatever reason, and they're desiring to have a vaginal delivery, those are also usually a one-to-one as well
Hold
because
on,
they're
you
high
what did
risk.
you call it?
A TOLAC.
A TOLAC. Is that an
Mhm.
acronym?
Yes, the acronym for trial of labor after a C-section.
Okay, I believe here it's a VBAC,
Okay,
right?
so then
Right?
if they were able
Or do you know what VBAC
um,
is too?
yes,
Okay,
so
then
let's say
I'm
that
messing that up.
no, 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 no,
Oh,
no, no,
okay.
you are on the right you're on the right track. So if our TOLAC patient successfully had her vaginal delivery, then we call her, oh, she's a VBAC,
Oh,
vaginal
gotcha.
birth after
After
a
a
C-section.
C-section. Gotcha.
Mhm.
Okay, so
Yeah,
before the
yes,
baby
you got
comes
it.
out, it's a toe back, and after the baby comes out, it's a V-back.
Yes.
Gotcha. Okay. Okay.
Yes.
Continue, continue.
Yes. So then, let's say I have a one-to-one patient and she has an epidural and she's like 6 centimeters and she's on Pitocin. Regular day for me would look like monitoring the strip like a hawk. I feel like that's every labor nurse, even if your patient's on meso. Um, we either have patients on intermittent monitoring, meaning they don't have to be on the monitor continuously, and that's usually for our early inductions or, our super young healthy moms. But if they're a little further along or they're high risk or they're on Pitocin like my patient, then we'll have them on the monitor continuously. And we're just watching the strip. We are titrating our Pitocin. So we're assessing our contraction pattern and we're assessing, is this baby tolerating this Pitocin and these contractions well? Yes. Okay. Our contractions are a little spaced out. Okay. Then we're titrating our Pitocin as needed. So we start with the low dose Pitocin of like 2 milliunits an hour, and we're able to titrate every 30 minutes as needed. So that's what we're doing. We're titrating pit. We're changing our patient's position to try and help open up the cervix. We use the peanut ball. We use the
Mhm.
stirrups to try different positions, and then also just educating our moms throughout. There's so much education in labor and postpartum, so I
For
like
sure.
to get my education out of the way once they're comfortable, or if they're early inductions, because it's just so much information and it can sometimes be overwhelming. And after they give birth, sometimes it's hard to listen. It's like, wow, I just gave birth. Like the last thing I want
Seriously.
to hear is about all of this stuff.
Yeah, I'm
So
just
you should
dead to the
over it.
world.
Yes, they're just so over it. So like educating like early on and when they're comfortable, they're like just sponges and they're listening to you and they're asking questions. And I like to involve our dads as well. Like,
Yes,
if you have any
please do.
questions, yes, just let us know. I mean, sometimes I like to delegate tasks to dads too, like
Yeah.
after we give birth and we have to keep track of like our feeds with the baby. I'm like, all right, dad, you're on our tracking duty. You're going to change the diapers, and then just showing them how to do it and then just watching them and then just letting them be free birds and do it on their own. And if they have questions, then we always tell them that we're here.
Yeah.
Um, So just educating our moms as well, like back to like what our day looks like as to the signs to look for. Like, what are we looking for? I tell them, okay, well, now that you have an epidural, things might look a little different, as into, oh, like when do I call Fernanda out? Or like, when do you want to know what? And I tell them any change is good change. So if you start feeling pressure that's coming and going, please let me know. If you start feeling pressure that is not going away, that is staying with contractions, without contractions, let me know too. If you feel like you want to have a bowel movement or like the urge to
Mhm.
push, let me know. Sometimes, like, their water can still be intact when they have an epidural. So I'll tell them if you feel a big gush or if you feel like a trickle, just let me know too. And then I'll also educate them because I mean, towards like your baby can look great at the beginning, but
Mm.
as we're progressing further down into labor, it's not uncommon for the strip to be a category two. Sometimes, babies can have variables and late decelerations. And I tell them, all right, when I come in here, sometimes babies can have drops in heart rates. So when I come in here and we're like, hey, we need to move, baby doesn't really like this position, you need to help me out. Okay. I'm
Mm.
not just doing it for funsies. I'm not just telling you this because I want to
Mm.
bother you and wake you up out of your deep sleep. It's because your baby is wanting a little bit of help. And
Yeah.
sometimes that can be fixed with a position change. So then they're more like, eat like, they'll help you a little bit more than when they see you come in, they will anticipate, oh, okay, oh, Fernanda's here. Oh, change position. Okay. And they're like helping you do it because sometimes it's hard when your legs are so dense and you have an epidural and you really can't move. So just educating them early on is, I precept as well. And I love telling all of my new grads, you'll find your spiel and you'll find what works for you and you'll know which pockets of education will fit where. I
Yeah.
tell them once they're comfortable, just letting them know like what to expect until the baby's delivered. So they're like mentally prepared is always well. And then also like talking about things that can go wrong once baby is born, like,
Yeah.
the shoulder could get stuck, mom could have some extra bleeding, and just having those conversations early on with my patients while we're in labor. And, maybe they won't have questions at that time because it's just so much information. I told
Right.
them, you might not have questions right now, and that's fine. But if you think of one, just call me. Just let me know. I want you to be prepared. So, and it helps a lot, especially for like patients who have like anxiety or if they're first time moms and they just don't know what to expect, then
Absolutely.
knowing it's like, okay, oh, they're pushing on my stomach. Okay. I remember them talking about this
Right.
earlier.
Yeah, just a
And
little more ease because everything
oh
is
yeah.
so scary. And
Yeah,
there's just
for
some
sure.
things, like, until you feel it. I remember in the beginning being like, "Oh, this sort of feels like period cramps. If this is real labor, I can do this." And then the real deal came, and I was like, "There is a demon inside of me." So,
Oh my gosh. Yeah.
very different.
Yeah.
Yeah.
Oh, for sure. And then yeah, education during my shift and hopefully we'll have a birthday party before I leave and our patient will call out and be like, "Oh, hey, I'm feeling lots of pressure." Check them, they're complete. I'm calling the provider. So we always have an OB in house, but
Okay.
the patient also has their provider. If it's either an OB from their clinic or a midwife from their clinic, they have their like own individual midwife OB provider. So then that looks like me calling the provider and telling them, hey, your patient's complete or your patient is +2 station, your patient's feeling lots of pressure. Then they'll come in, or maybe they're already there in one of the sleep rooms. So then the provider will come in and our then we'll start pushing. Our midwives push with our patients, which is pretty cool
Oh.
and not very common is what I was told by our travel nurses.
Okay, 2 questions. First is,
Mhm.
like, my story said I had a midwife and then but she works office and, office, OR, and birth room.
Mhm.
But she wasn't on, so I had another covering doctor. So what you're saying is if I was in Alaska, I would always have had my midwife or my the person I had been seeing for prenatal?
Yes. So,
Ah,
unless she's on vacation, then maybe not. Maybe she'll have another midwife from that clinic cover. But for the most part, you'll have the midwife that you've seen for all your prenatal cares. She'll be the midwife that delivers you. We have different clinics here in Fairbanks. The only clinic, which is our native clinic that sees all of our native patients, they rotate. So they have their OBs and they have their midwives, and they rotate the days that they're on call. They'll see all the different patients, and depending if they have any of their clinic patients in the hospital, they will deliver that patient. Sometimes
okay.
our native moms will know, like, "Oh, yeah, I know XYZ midwife. I saw her for 2 visits," or, "Oh, yeah,
Yeah,
she's the one that
right.
checked my cervix a week ago for
Yeah,
my prenatal appointment."
yeah,
So
happens.
they're mhm. So that's with one clinic, so it's
I
just
see.
mhm.
Okay.
And yeah, so then midwife will come in, will push,
What do you mean by
and
that? They push with the patients.
what I've been told by our travel nurses is once the patient's complete, they want to start pushing. So then the nurse will push with the patient, and whoever is listening to this and is a labor and delivery nurse is going to probably think this is crazy, but
Okay.
our midwife will push with the patient. So myself and the midwife, we're coaching the patient, we're changing the positions, we're pushing for however long we need to push. What that looks like in the lower 48 or like most hospitals is the nurse is pushing with the patient. Once the baby's like crowning, then we're calling the midwife and it's like, all right, come in here. Or
Uh-huh.
the OB, all right, come in here. Then we'll have the OB come, baby's like crowning, then just deliver. Like they call the people in the lower 48, they will call the provider after the nurse has been pushing with the patient for, I don't know, 30 minutes, an hour, 2 or 3. Hey, she's crowning. All right, here we go. And they
Okay.
just catch the baby.
Yeah.
They'll just catch the baby.
I think that's sort of what happens, right? Except the pushing part. I mean, do you mean like the breathing and pushing? It,
Like the coaching. So it's
oh, okay.
like
Okay.
the midwives do lots of coaching,
Mm,
um, guiding,
that's nice.
if they need like if they have a really dense epidural and they don't know where to push, sometimes like helping them, it's like, do you feel like my fingers right
Mhm.
here?
Mhm.
Is this helping? Like, are you feeling okay? It's like, oh gosh, yeah,
Yeah.
I don't even know if I'm pushing okay. So sometimes they
Yeah.
need that extra help.
Yeah.
So our midwives are very hands-on and very involved with like the care in that last stage of labor.
That's really awesome. And
I know I'm gonna miss it.
yeah, that's awesome. I feel like for my 3, the I remember especially my last one because from what I've heard and also with my experiences, they all went faster with each baby. So
Okay.
like
Okay.
the first baby, I actually had a pushing time. The second one, I
Mhm.
remember just like screaming, "This thing's coming out of me," and I have no control. Like, no, like he's I'm not doing anything, and my body is just like crushing him out of me. Like, and I remember
I love
my
it.
friend was my nurse, and she was like, "You cannot push. I need to get the doctor in here." And I was like, I'm not doing anything. This thing's just
I'm
coming out." And I remember her like putting on, and she's like, "Oh, okay, well, I'm gonna catch a baby. I'm gonna catch a baby." And I
Yes.
remember the doc coming in and just throwing her gloves on, and I didn't know that lady at all. I did not like her bedside manner. Just saying. And she just caught the baby, and
Yeah.
that was it. Like there was nothing else. I mean, I practically caught my own baby. I mean, at that
Yeah.
point. So, yeah, so in the event where, like, there's less push time, what happens? Is the midwife still there? Like, when does she when how did what happens?
So let's say it's a midwife, like, taking care of the patient here in Alaska, or particularly in the interior where I work, then they'll come in and it's not like, "Alright, start pushing with the patient." It's like, "Oh, okay, it's a small town." Like, I think the furthest a midwife has told me that they're coming, it's like, "Oh, I'll be there in 20 minutes."
Mm,
If I call a midwife and she's at home, it's maybe, like, average 10 or 15 minutes that they're here, or,
okay.
like, if they already knew that this patient's 8 centimeters and before I even got to the unit, then they might already be in-house, or they're like, "Oh, this is a multip," or, like, "This is her second baby, she's probably gonna go quick. I'm just gonna stay here. Call me, I'm just downstairs." So
Gotcha.
they're not super far either. So just
That's
kinda
great.
communicating, and depending on, like, who we're taking care of and what baby number it is and how
Yeah.
dilated they are,
Mhm.
just depends. Is the provider in-house or is the provider at home? Do I need to call a little sooner? Because the provider's not here, it's just, big picture wise trying to figure out, okay, like, you also don't want to call the provider super late and they miss the delivery.
Yeah.
Um, but if we have a patient that goes like from zero to complete, we have our OB in house that can come catch the baby if needed.
Gotcha. Okay. So
Hmm.
say now you had just delivered a baby, a healthy baby.
Hmm.
How would your day continue?
So people that would be present there would be our transition team. So this will involve two of our NICU nurses. We have a level two NICU here. So they help us with the 4 hours of transition at the beginning. Like, so once baby's born, they're caring for this baby. They're assessing for the APGARs, or making sure that the baby doesn't need any extra respiratory support, or maybe even have to go down to the NICU. So they'll take care of the baby for the first 4-ish hours. And then for us, then we'll keep our mom. Hopefully she's not hemorrhaging, or she doesn't need any like additional medications. But if needed, we have a postpartum hemorrhage kit in our Pyxis that is readily available if we're already anticipating, oh, she has a history of hemorrhaging with her other babies. We can prophylactically just have it at the bedside in case we need it. Um, we'll have Pitocin. Most of our patients, if unless they're like refusing, they'll get postpartum Pitocin, and this is going to help control the bleeding after delivery. And then we'll have our provider assess the perineal area to see if there's any sort of repair that needs to be done. Then they'll do that. Then we'll go ahead and get the patient comfortable. We'll turn off the epidural after the repair is done, and we'll start our recovery stage. So we're assessing the bleeding every 15 minutes with all of our vital signs, just to make sure that the bleeding's under control. And then we'll be doing that for about 2 hours. If there's no one waiting for me, I'll probably keep my patient and then get her up, have her try and pee after, just to make sure that she's able to void on her own, and just educating her on, okay, now we're at the 2 hour mark. I'm not going to be checking or bleeding as often as I have been doing. So just kind of letting her know, like, I'll help you, you help me. This is what we're looking for. Like, it's totally normal to have some bleeding when you're doing your position changes. But if you find yourself saturating one of these pads in an hour or
Mhm.
faster than an hour, I want to know about it. If you're feeling lightheaded or dizzy, like, don't get up by yourself. Like, call me and let me know. If you're passing blood clots like the size of an egg or a golf ball, I wanna know about it too. If you're concerned about any bleeding, if you don't know if this is too much, or, just call me, and I would rather you be safe than sorry, and
Mhm.
we can take a look at it together. And then if she does well, like the first time getting up, then I'll tell her, "I'm comfortable with you getting up, but, I'm always happy to come in here and help you if you need that extra support." And I'll tell them, "I think you look fine right now." Um, and then catching up on charting always. um,
That doesn't change, I guess.
yes. So just charting my strip and charting the delivery and charting in the assessments and like the recovery part of it. And maybe, you know, if it's appropriate, if no one's waiting on me, then I'll go take a lunch and I'll have somebody watch my
Good.
patient. And then our unit's pretty good about having us get lunches.
That's
Um,
nice.
I joined like the labor and delivery nurses rock page on Facebook, and I've seen like people make posts like, "Hey, how do you guys get a lunch?" Or it's like, "Hey, I feel like my unit is struggling to really get us lunches. Like, do you guys have a system or
Mm,
blah, 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 blah." And just seeing how much people struggle, it's like, oh, I'll eat at the desk, or oh,
yeah.
we have a break room and they have like a big screen TV and you can see the monitor.
Ugh.
So if you need to go fix your patient, then you can go. I'm like, what
Yeah.
is happening?
Like, is that
But
real?
I know our yeah, like if no one's in triage and our triage nurse is available, then usually they'll be able to watch our patients while we go take a 30 and then come back and continue just caring for our patient. And hopefully by that time it's 7 a.m. and we're giving a report to day shift.
That's awesome. And you, so is in Alaska, you take your breaks as an LD,
RP.
RP, labor and delivery, recovery, postpartum.
Hmm.
Yeah, okay.
Yes.
And
Yeah.
does the patient ever move rooms?
Um,
I didn't hear that. Like,
Not yeah, not usually. I mean,
okay.
if our unit is, like, booked and busy and we need a labor room, then we'll go ahead and switch them to just a regular C-section room. They're a little bit smaller, they don't have, like, the monitors, the beds are different, you're not able to break down the beds for, like, pushing in stirrups.
Yeah.
Um for the most part, no. Like, they'll
Oh,
stay in that room.
well,
If
that's
there's
nice.
if there's open labor rooms, which usually there is, it comes in waves, they'll stay in that room until they get discharged.
Cool, because from what I know, I typically see like the labor and delivery nurses in one area, right? And there's like the OR somewhere close by. And then I literally like went through big doors and then I was in postpartum and I don't go back. Like they're totally separate. Like I don't see those nurses again.
Yeah, oh my gosh, that's so funny. Yeah,
Yeah.
no, we're all the same. Our assignment changes. I don't know if there's, like, a rhyme or reason behind it, like, "Oh, on my first shift, I'll be labor, on my second shift, I'll be postpartum, on my
Yeah.
third shift,
Mm.
I'll be triage." Not really. I mean, for me, I know because, like, I'm precepting, so we're in that part where we're doing our labor, orientation, so I know coming in, I'm always gonna be labor. At the beginning of, the new grads, when they were getting precepted, it's a month of postpartum, so I just knew that we were gonna be postpartum. Um,
I see. Oh,
Sometimes
okay.
yeah, yes. So, I mean, for, like, just somebody who isn't precepting, like, you don't know what your assignment is going to be, if it's labor, delivery, if it's postpartum or if it's triage. It's just
Okay, so you basically rotate, you can rotate or fit in all of those roles,
Mhm,
but not in one shift. Is that what I'm hearing? Well, no, because you can continue taking care of the mom after
mhm.
labor. But do you
Yes,
get that mom back the next day or
so let's say it's totally appropriate and common for you to start off as a labor nurse and end as a postpartum nurse when you're giving report. So it's like,
Right.
let's say you delivered, like, let's say there's, I don't know, like 3 patients in labor and you deliver your patient, you're recovering, and somebody else delivers their patient and they're recovering. Now we have 2 recovered moms. One of the nurses is going to give report to the other nurse. So now this nurse has 2 couplets and the other nurse is completely free to go take the next labor patient.
Yeah.
So then
Right.
you have your 2 couplets. So now you went from labor nurse to postpartum nurse. you have your 4 patients, 2 moms and 2 babies, and if it's a super busy night and we're just popping babies left and right, then you would anticipate getting another couplet once the next laboring mom delivers.
I
Then you'll
getcha.
end up with 3 couplets by
That
the end of
makes
the shift.
sense.
Mhm.
I have sort of a quirky question. So, obviously, temperature changes, right? And the differences in Alaska. Um,
Mhm.
Here, I don't know if it's the same there. We get those blankets that have a blue and pink stripe. They're white and they have blue and pink stripes, and the matching
Mhm.
hats. You guys also do use those?
We have those blankets, and then we also have the blankets that have the little, like, hands and feet that are, like,
Oh yeah,
pink
yeah.
and, blue, and then we yes, so we have that one, we have the handprint one, and we also have, one that has, like, these hot air balloons.
Okay, okay, that's
And
cute.
then we also have those, like, stretchy hats that have those pink and blue stripes
Yes,
that are, like, super stretchy.
yeah.
So, yes, we have that.
Oh, that's funny. So it's over in Alaska too. I wasn't sure if,
Yes,
like, you
yes,
guys
it is.
have, like, furs and cool stuff. So, what about, like, babies leaving the hospital? Like, do all the parents have, like, something in particular for, like, keeping them warm in those temperatures, or am I overthinking things?
Um,
Like, obviously,
I
here
mean,
we have, like, the covers, right? Like, it can get pretty cold in New England in the winter,
yes.
but, not
Mhm.
and then I think I saw one of your videos and it was, like, -29 or something, and I'm like, "Holy crap." And, like,
Yes.
a little brand new baby in that, it's like, and
Mhm.
plus there might be some travel, especially for those going off to villages that are far.
Right.
Um, yeah, like, how are they what are we using out there?
So, honestly, I don't haven't seen, like, anything, like, super extraordinary or, like, just completely different. Um, they'll have the covers as well. They'll have, like, a layer of clothes on the baby, and maybe they'll have, like, a blanket over the baby, but I think just knowing that when they're discharging, it's, like, from the hospital, um, door to the car is
Yeah,
maybe, like, 10 seconds, so it's not like we're bundling up this baby, like, too much, and it's not like we're requiring, like, "Oh, your baby has to have this amount of layers before you leave the hospital." I know it's a little crazy, but it's not we don't do
y
anything,
you're
like,
just used to it.
super special. Yes, I think so, and I don't know, I think not that, like, Alaskan babies are built different, but, like, I will see, just moms out and about with, like, their baby, like, carrying the baby just kinda covered. It's not they don't, like, overthink it. I
Yeah.
wanna say it's because, like, babies grow out of this stuff super fast, so I guess investing in, like, very expensive warm clothes, could probably be, not a good investment, but it's nothing too crazy, maybe like a snow, suit or something on the baby later on, but I don't see that, like, in the hospital or anything.
Right, that makes sense. I feel like, I have family in Canada and, like, every age snow gear, like, all
Yeah.
the time, so that makes sense, okay. Um, I have a couple more questions for you, and they're
Yeah,
sort of, like, generalized to
sure.
close. So, the first one is, do you have if you could share a lesson that your career has shown you in labor, delivery, recovery, and postpartum, what would it be?
A lesson. Let's see.
Yeah, like a life lesson, something that was really that's become eye-opening or really changed you from your experiences, or maybe something that we really don't realize, for those of us who aren't in labor and delivery. Like, for
Mhm.
instance, as a student, a lot of times people think labor and delivery is, rainbows and butterflies and, you know, yeah, lots of
Right.
happy moments, where in fact there's lots of scary moments. Um,
Mhm.
so I feel like there's so many life lessons, I mean, you're literally bringing life onto this earth. It's just like
Yes.
so many experiences in one day. In one really?
Right. Right. Yeah, I think, yeah, when you were saying that about like students, I think that's what I feel like this is something that people don't really know about labor and delivery, that we're not just holding babies all night. Like, I think I don't even know. Like, I think the only time I really hold a baby is when I'm putting the baby on the scale to weigh it in the morning. It's not, I really don't have time for that. And yeah, I think something that people don't know about is that about labor and delivery and postpartum is that things can go sideways very, very fast.
Yeah.
Like, we can probably just be pushing with the patient 1 minute and we're rolling to the OR like the next minute, and how quickly like patients can deteriorate.
Mm,
Like one time, like you will have your patient like talking to you, baby's coming out, everything's like rainbows and sunshines, and we can't believe it. And then the next, it's like we can't control the bleeding, the
mm.
patient's looking pale, the blood pressure is tanking. Now we have ourselves a postpartum hemorrhage. So now we're really just quick on our feet, calling our friends, giving them medications to control the bleeding. And, that stuff's scary
Oh
sometimes. And
God,
it's
yeah.
like,
Yeah.
it shakes you up. It's like how quickly somebody can lose blood. I mean, just seeing like a waterfall come out of,
Wow, yeah.
you
Yeah,
know,
yeah.
the same area that this baby came out, or having these blood clots, or just pushing on their stomach and seeing it's just like the biggest gush you've ever seen. It's like, oh my goodness, what is happening right now?
Yeah.
Um,
Yeah.
yeah, just how many things can go wrong in labor. It's not as easy as, yeah, I'm going to the hospital, get induced, and have a baby. Like
I
there's
know.
so much that can go wrong. And sometimes these things,
Yes.
like you can't prevent these things. Like
Right.
you can't prevent a postpartum hemorrhage. You can't prevent your baby getting stuck, their shoulder getting stuck, or having a fourth degree tear. Sometimes like these things just happen, and um it's unfortunate, but at the end of the day, as long as we have a healthy mom and a healthy
Yeah.
baby, I feel like that's our goal.
What's your favorite or best part about being an a labor delivery postpartum nurse?
Seeing my patients out in the wild.
Oh, really?
Yes, it's a small town. So it's so common to see people at the grocery store. We only
Right.
have one Walmart. We only have one Costco. We don't have every chain restaurant like the lower 48, like seeing
Okay,
them at
hold on. What
church.
is the lower 48? What is that?
Um, so we're Alaska, then there's Hawaii. The lower 48 is the rest of the US, the 48 states.
Oh, okay. Okay, I get it now.
Yes.
Okay, that might have been a
No,
completely dumb question of
no, no,
mine, but
no, 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 no. I didn't
I
even
was
know
like, "Is
that
that
was
a
a
zip
thing.
code?" Like, what is that? I don't know.
Yes, no,
I getcha.
it's so funny because when I first moved here, I was, what is the lower 48? What are you guys talking about? It's like all like the rest of the US, the lower 48. And I'm
Yeah.
like, oh my gosh,
I'm like,
that
"Is
makes
this
so
a
much sense. Like,
temperature?" Like, I don't know.
yes.
I get it
I'm
now.
like,
Okay.
I didn't even know that was a thing. It's like, yeah, it's something that like people in Alaska use to
Yeah, yeah.
like very often actually. It's like, yeah, I'm gonna go visit my family in the lower 48, or we're moving back to the lower 48, or it's like I just got
Oh my
back from
god, like it's like
vacation.
this little spot or something, right?
Yes,
Like
yes, yes,
oh
yes.
my god, that's
So
crazy. Okay.
yeah, I don't think that's gonna happen, like, once we move back to the lower 48, but yeah, that's my favorite part, just running into people, because I only get to see, like, these babies, like,
Yeah.
when they're 1 or 2 days old. That's
Right.
it.
Yeah.
That's
Yeah, that's
and
it.
and then just seeing how much they change so fast,
I
I'm like,
know.
"You just gave birth a month ago, like, who is this child right
I
here?"
know. It's so sad. You
I
know?
know, yes,
It
that's my favorite part.
it's funny you say that. I look forward I'm gonna do a podcast episode with my best friend eventually. I want to get her on here. And, we can sort of compare some of the things too, especially because she's my best friend and she's, done a couple of
Mhm.
things to my body, which you had never expected. Um, but I remember, after, like, after I was discharged from the hospital, she had
Mhm.
no idea what to do with my child. Like, yeah, she was just like, "I just, like, deliver them and stuff, like, I don't know what to do now."
Y yes, yes,
I'm
oh
like, "Wait,
my
aren't you
gosh,
always
that's
around
so
babies? He won't
true.
stop crying, do something." And she's just like, "I don't know." I'm like, "Okay, that's not helpful."
Oh my gosh, that is so true
Yeah,
because I feel like people think we know everything about babies. I mean, for
yes.
me, I only know this about this gestation of
This
babies. I know
yeah, exactly, it's
w
so
like, you have a 7-day-old? I don't know. Call the pediatrician.
Wait, does it have teeth yet?
Oh, yeah.
Although some do at birth. Uh,
Yes.
that yeah, it's
Oh my
true.
god.
Alright, last question. Do you regret becoming a nurse?
No. Mm-mm. I freaking love it. I think I love how diverse nursing is, and I think
Yes.
that's why I went into it because
Yeah,
it's like, if I don't like what I'm doing, then I can do something completely different. Like, I don't have to work bedside forever. I can
absolutely.
do like and then you can travel too, like
Mm,
travel nursing, you can take contracts. Like, I just came back from this remote town in Alaska. It's called Nome. And I was there for the Iditarod, which is like a dog sledding
I
race.
saw some of your
And
videos.
yes, oh,
So
it was so
cool.
much fun.
God.
Yes. And you know how people like to go to museums when they're out of town? I like to go to hospitals. I love that.
What?
I wanna see the structure. I wanna go in and just take a look around and see how different these
No,
hospitals
I
are.
I get
So
it. It's
I
like part of the culture. It's almost like a museum in a sense, right? I guess.
oh, yeah,
Like,
for
yeah.
sure, it's my museum.
Yeah, it makes
And then
sense.
I'm like, the worst I can say is no. So there I am, like in the hospital, find the labor and delivery unit, go to the labor and delivery unit, and I'm like, "Hi," and they're trying to open the doors, and they're like, "Oh, are you going to labor and deliver?" And they're like, "Yeah, okay, I'll badge you in." I'm like, "Perfect." I walk in, go to the nurse's station, and I'm like, "Hi, I'm Fernanda," and there's the nurse like, "Hello," and I'm like, "Can I get a tour of the unit?" And she's looking at me like, "Who the heck are you?" And then I told her, "I'm a labor and delivery nurse. I work in Fairbanks, blah, blah, blah." And then I said, like, some sort of sentence for her to, like, know I'm not joking, like, you know, maybe, like, some nursing lingo. I threw some
Yeah,
nursing
yeah.
lingo in there. So she's like, "Oh, okay, you really are a labor and delivery nurse." It's like, "Sure, yeah, let me go ahead and show you." She shows me the unit, 2 rooms, that's the unit. 2
Wow.
labor rooms, and it's basically like the summary of this unit because I told her, "Oh, I'm visiting Nome and I don't know, like maybe one day I'll take a nursing contract out here. It's so beautiful. Like I would love to like come here a little bit longer next time." And she's telling me, "Yep, this is our unit. We have 2 labor rooms and this is our triage, this is our postpartum, this is our labor, this is our everything." And I'm like, "Oh wow, cool." And she told me they don't have an OB, they don't have midwives, they don't have anesthesia,
Whoa.
they don't have CRNAs. Epidural is not an option for these moms. So they go
Wow.
into it knowing that they're going to go natural. They have nitrous oxide, they have IV pain medications, they have a birthing ball. I'm like, "What? What do you mean no epidural?" She's like, there's no like, we don't have anesthesia here, like, we and I'm like, "Oh my
Yeah.
gosh," and she told me, "And in the event that we have to perform an emergency C-section, we're doing it in this room."
Oh,
What?
wow.
The labor room? You're doing a C-section in the labor room? It's like, yes, like, if the baby's not recovering and the baby's down in the 50s and it won't come back up, we're performing a C-section. And
Wow.
I'm like, "And who does it?" And she's
Yeah.
like, "Our family medicine doctor does the C-section." And I'm like,
Oh.
I was mind blown. I'm over here like, wow, this is
It's just
remote
so
Alaska.
it's so amazing, like, the things that are out there, you know? I love that. I love that you
Yes,
do that. That's, like that's so cool. Yeah.
yes, and I'm just like, I was just so mesmerized, and
Yeah.
the whole time my jaw's on the floor, and she told me, "I'm not trying to scare you, I'm just, like, letting you know, like, this is like, if you ever wanna take a contract, like, this is how it is."
You're like,
And
"Hmm."
I'm like, "Oh, okay, sounds good," but I'm like, "That's so crazy," and
Yeah.
she's like, "Yeah, so, I mean, if we only deliver, like, low risk patients, like if they
Right.
have any like comorbidities, like if they're like pre-E or anything, she's like, we're shipping them
Yeah.
to Anchorage or to Fairbanks. We don't deliver high risk patients here."
Right, right.
I'm
I
like,
mean,
got it.
wow. So maybe that's part of that, culture, the native culture, like you were saying. They're stoic, they're expecting no epidural.
Hmm.
This is it. And yeah, I think that shows so much about, the native Alaskans and how strong their mindset is. At
Hmm.
the end of the day, I feel I can say this having 3 kids, it's all in the mind. Like, it's all about, like, as far as having a healthy vaginal birth, of course,
Right.
being able to control your mind and telling yourself, this, my body was made for this. It knows what to do. Trusting your
Hmm.
body. It's really true, except it's just hard to believe that the first time because you're like, what
Yeah.
is happening?
Yes. Oh my
But
goodness.
if it wasn't for my nurses and all so many of those times, like just something as simple as stop scrunching your forehead. I remember relax your forehead. I was just like, oh, just that, and I was like, like,
Yeah.
let go, or ease your hands, let go,
Yes.
relax your
Oh my
head,
God.
like just the
Yes.
little things, and it helps you
Right.
focus, refocus. And I always told myself, the pain will come, but it will go. It has to leave too. So
Right.
yeah,
Oh my
but
gosh.
you
What
guys
kind
are
of nurse are
awesome.
you, Courtney?
So when I started in med surge and then I
Okay.
became a float nurse, I never did
Okay.
critical care. I always wanted to. I always thought I would. But
Yeah.
then the transition didn't happen between having to work nights because when I was in nursing in the beginning, you didn't get hired in the units. You had to have like
Okay.
experience, blah blah blah. Now it's like new grads can get hired, but it wasn't like that for me.
Yeah.
So once I started floating, I became per diem because I went back to school, and when I was able to have such a much more flexible schedule. I mean, nobody wanted to work
Mhm.
with me from my schedule before. So and I couldn't do nights having to go to school. Um
Right.
and bless everyone who has. Anyway, so yeah, then when I graduated my grad school, I then went into, which I never thought, long-term care, but it which sounds crazy, but um, it was a great job. There was so much support, and I was in multiple facilities. And as you know, the hospitals now are sending people out after your like 3 days, right? Like they need to kick people out. So
Mhm.
it was like miniature hospitals, and I was covering 11 buildings. It was horrible. I didn't know like a lot of
Gosh.
my patient, whatever. So I got lots and lots of experience. Long story short, I am now in hospice and palliative, and it is the best. Like, I feel your passion. I have my passion in this field. I learn something new every day. That being able to share in a dying experience is beyond a blessing. I am so fulfilled, just every aspect, my flexibility and everything about it. So, yeah, we never
Yeah.
know where our paths will lead. I mean, did you ever think you'd be in Alaska? like,
No,
like,
absolutely not.
yeah,
Yeah, I remember being in nursing school, I was scrolling on TikTok and I saw this video of this girl who's like super known here in Fairbanks. Her name's Alaska Lizzie, and she
cool.
posted a video saying, "Oh, these are like kids in -30-degree weather going to school," and she's opening the door. She's working at the elementary school. She's opening the door and these kids are leaving and you can see like just all the wind coming in and all like this like the wind fog just
Yeah.
coming in through the building. And I'm like, I didn't even know places like that existed. I told myself I would never live in a place that's -30. That's insane. And here I am in that same town, living here
Wow.
for 3 years. And I told myself, wow, this is crazy.
Yeah.
But, I love it. We get to see the northern lights during our
I
shift,
saw
and
some of that
we
those shots, unreal.
it's so beautiful, and then you get to have your lunch break at 2 in the morning outside because
I
it's
also
daylight
saw that. Yeah,
24/7.
it's just
It's
unreal.
very it's very unique, and anyone who, like, has ever thought of getting, like, a nursing contract in Alaska, just freaking do it. It's absolutely amazing.
Wow. Well, I thank you so much for sharing your story. Really, I hope this encourages lots of nurses out there, not only to get into labor and delivery, but really seeing your passion traveling, the courage you have. You should be so proud of yourself. You have so much courage, especially as a brand new nurse hopping over to Alaska. I mean, really, like you just did everything at once and like you're thriving. So, congratulations. Honestly, you're awesome.
Thank you.
It was
Thank you
so
so much,
nice
Courtney.
chatting.
Yes, of
I'm
course.
just gonna stop it here. I also want to share.